Good morning, good afternoon, good evening. Thank you so much for joining today. I'd like to welcome everyone to the STS 2026, the very first STS 2026 webinar series. Today's webinar is titled STS South Asian Webinar Surgical Management of Infectious Lung Diseases, and we're so pleased to have it co-sponsored by the Society of Thoracic Surgeons, the Indian Society of Thoracic Surgeons and Trust, ESTS Women in General Thoracic Surgery, and the Indian Association of Cardiovascular Thoracic Surgeons. Please note this webinar is being recorded and will be available on the STS website and YouTube channel. At this time, I'm pleased to introduce Dr. Mashuri Rao and Cecilia Pompili, who will give an introduction and introduce our moderators for this webinar. Dr. Rao, let me turn it over to you.
Thank you, Karen. Welcome, everyone. Happy New Year, and good morning, good evening, good afternoon to everyone joining from everywhere. I'm truly excited to be co-hosting this STS South Asia collaboration with the ESTS, ISTS, IACTS. It's a true reflection of what global collaboration can look like. And I'm honored and excited to be here as part of this. And I'm very thankful for the support that we've had from the STS on this. We have with us today uh, leaders from all the different societies representing us. We have Dr. Andrade, who's the vice chair for the SDS International Education Task Force. We have Dr. Pompili here, who's the president of the ESTS, Women in General Thoracic Surgery, and a board member of the ESTS. And we have all our leaders from the Indian Society of Thoracic Surgery. This is our second thoracic webinar as part of the STS South Asia collaboration, and the first one that's also collaborating with the ESTS. Um, without further ado, I'm going to hand over to Dr. Pompili to introduce the ESTS part of the collaboration. Thank you.
Thank you so much, Dr. Rao. I think, again, welcome to everyone, and I'm very proud to represent certainly ESTS, but in particular, I want to mention the South Asia chapter that together with Dr. Rao, we managed to build over the last couple of years within the Women in General Thoracic Surgery Committee. I think this chapter is an expression of the dedication of supporting this global collaboration. Of course, primarily through the connection of women across the globe, but definitely also as an occasion to collaborate broadly through the ESTS that has always been very, very open to South Asia and other countries. So, without any doubt, I want to again thank all the societies involved in this webinar, and I will pass over back to Dr. Rao to introduce the moderator. Thanks again.
Thank you. Dr. Sri Krishna, can you kindly introduce the moderators, Dr. Rajan Santosham and Dr. Ravindra Devan? Before doing that, I want to introduce Dr. Sri Krishna. He is the current president of the Indian Society of Thoracic Surgeons and has a vast experience in infectious disease management. And he works at he's the chief of thoracic surgery at Narayana Hrudayalaya in Bangalore, which is in South India. Dr. Sri Krishna, please feel free to add to that, and please introduce our moderators for us. Thank you.
Thank you, Dr. Madhuri. Good day to all of you. On behalf of the ISTS, it gives me great pleasure to welcome you all for this webinar on infectious lung diseases, which is a major challenge in our part of the world. I'm also honored to introduce to you the moderators for this webinar. Dr. Rajan Santosham, founder president of the ISTS, and presently the patron of the Society Needs No Introduction. He is considered as the father of thoracic surgery in India and has more than 5 decades of experience in establishing thoracic surgery in India and responsible for training many of us. He started his career way back in the early 1970s, learned the nuances of thoracic surgery under the able guidance of his father, Dr. Madhuram Santosham, and is presently the chairman of Santosham Chest Hospital. He is also the senior consultant in the Apollo hospitals in Chennai. He is a well-known international figure and an invited speaker in many national and international forums. The next person is my close friend, Dr. Ravindra Kumar Diwan, the present Vice President of the ISTS. He was the director of NITRD and the LRS Chest Hospital in Delhi, and now continues to be the Professor Emeritus there. He has perhaps the most experience in surgical management of pulmonary tuberculosis and many innovations in the treatment of drug-resistant tuberculosis. He has conducted various training programs, both nationally and internationally, in the surgical management of TB, and has also published numerous landmark articles pertaining to the same topic. I now hand over the proceedings to these two esteemed dignitaries to conduct the webinar. Thank you.
Thank you, Dr. Sri Krishna. Dr. Rajan Santosham, could you kindly
Can you see me on the screen?
Yes.
Can you hear me? Yeah.
Yes, we can see and hear you.
Yes, we can.
My job is to introduce the speakers. Dr. Pallavi Purwar is a thoracic surgeon, and she's a very important thoracic surgeon from our country. She is based in Delhi and works in the Holy Family and Kailash group of hospitals. She has done a doctorate in thoracic surgery and has been interested in TB surgery, and she trained with Dr. Ravindra Kumar Diwan many years ago. Her long-term goal is to make thoracic surgery more accessible and affordable to all sections of society and help young surgeons to take up thoracic surgery as a preferred specialty. Now, thoracic surgery per se is very active in India, with a lot of young surgeons taking active interest. Earlier days, it was only cardiac surgery which had the name, fame, and money. Now there is enough of name, fame, and money in thoracic surgery, so things are changing in India. And can I introduce Vijay also?
Yes, please.
Yeah. Dr. C.L. Vijay is a consultant thoracic and robotic surgeon, Sparsh Group of Hospitals, Bangalore. In the past, he held consultant post in the Department of Thoracic Surgery in Narayana Hridaya Hospital, along with Sri Krishna. After finishing his surgical residency from the reputed All India Institute of Medical Sciences, New Delhi, was selected for the DNB thoracic surgery course. We must remember Dr. Babatosh Biswas, who was responsible as a Vice Chancellor of the West Bengal, Calcutta University, to start this course. He did the first thoracic surgery training program, and he got the best candidate award for that. His key areas of interest include minimally invasive thoracic surgery, VATS, and RATS, thymic surgery, airway surgery, and lung transplantation. Thank you.
Thank you, Dr. Santosha. I would just also like to add that Dr. Pallavi Purvar is our lead for the ESTS Women in General Thoracic Surgery South Asia collaboration, and I'm very thankful for that work she's been doing as well. It is now my pleasure to introduce Dr. John Mitchell. Thank you so much, Dr. Mitchell, for joining us today to give us a perspective of the infectious diseases in the Western world. So Dr. Mitchell is a professor of surgery and the chief of general thoracic surgery in the Division of Cardiothoracic Surgery. And he holds the Courtney and Lucy Patton Davis Endowed Chair in Thoracic Surgical Oncology at the University of Colorado. His main clinical interests are basically in infectious diseases, but also in lung transplant and lung cancer. And his interests include all of thoracic oncology, surgery of the airway, surgery of esophageal surgery, and robotic and minimally invasive thoracic surgery. He's also a member and has several leadership roles in national and international professional groups. He serves as the STS executive on the STS Executive Council as the treasurer, and he's also the current vice chair of the American Board of Thoracic Surgery. He's also on the ESTS working group for infectious diseases and chairs that committee. So thankful again for you joining us this morning, and we will proceed on to the talks. Thank you. Dr. Pallavi, I think you're going with yours.
Dr. Pallavi, you can start, I think.
Hi, I would like to talk about open surgical strategies for pulmonary tuberculosis sequelae. But before we talk of sequelae, I must mention that the greater resurgence today is in surgery for MDR and XDR tuberculosis, especially in patients with cavitary MDR tuberculosis, as well as patients with active ongoing hemoptysis. So before we move on to the sequelae, I just wanted to highlight that point. Now we move on to the sequelae. The three sequelae of surgical importance include destroyed lung, fibrocavitary diseases with bronchiectasis, and aspergilloma. So aspergilloma and bronchiectasis constitute the major diseases which are definitely and directly benefited by surgical procedures. They can present with persistent infections, recurrent hemoptysis, progressive dyspnea, poor quality of life, and persistent infection and recurrent hemoptysis are two things that surgery can completely solve for these patients. So whenever disease is anatomically localized, we should offer surgical resection to these patients. Although the evidence still is evolving because there are not many published RCTs on this subject, but surgical goals of eradication of infection, control of hemoptysis, and improvement of quality of life are definitely achievable, and this has been proven across studies. So what are these sequelae that we are really talking about? One is aspergilloma, which may be a simple aspergilloma, which is a classical air crescent sign, or a complex aspergilloma, which destroys the adjacent lung. In TB, the incidence is reported from 0.16 to 17%, and especially in patients of cavitary TB, it could be 11 to 17%, and these can present with hemoptysis at any time. So it is
Excuse
also
me, Dr.
important to
Pawar, will
Yeah.
you put your presentation in slideshow mode?
Yeah, sorry.
Thank you. That's okay. Thank you.
Yeah. So when we talk of aspergillomas, the debate still continues whether or not to operate, but I will show evidence which supports additive surgery definitely bringing a positive contribution. Bronchiectasis happens in up to 60% of TB poor patients, and it is different from the bronchiectasis that occurs due to other causes like cystic fibrosis or because bronchiectasis in TB is generally localized to upper lobes only, and hence these patients are more often than not resectable. And second important difference is that we can sometimes even get away with smaller segmental resections if we have post-TB bronchiectasis. We don't have to remove the complete lobes in all patients. So coming on to aspergilloma, the most common presentation for which surgery is recommended is hemoptysis. Whether or not to embolize is a decision based on patient's general condition. If there is active, ongoing, significant hemoptysis, then a preoperative embolization as a temporizing measure helps improve outcomes, because otherwise the morbidity can be high. We have to stabilize the patient, optimize the nutrition, control the active infection before we offer surgery. So timing of surgery is important. Operative planning is also important. In patients with a simple aspergilloma, we can do a less than lobar resection. But if it is a complex aspergilloma, then you have to do a complete lung resection. So if you look at all the studies before 1997, then the complication rates were for aspergilloma surgeries were pretty high. But with the modernization, with the advent of VATS, with the advent of airway, better intraoperative anesthesia management, ERAS protocols, digital suction devices, the complication rate for aspergilloma surgery has significantly reduced. And this one surgery, which used to consider to be having a high mortality of 25 to 30%, is now down to less than 5%. And hence, the debate that used to be very common in TB spaces earlier of whether or not to operate an aspergilloma, and the world was divided. If we looked at the Russian side of picture, then everybody was offering surgery. But in the West, surgery was not very commonly recommended. In East, that is our part of the world, we have always been recommending surgery with good outcomes. So now most of the latest guidelines have come up with the conclusion that even if asymptomatic aspergilloma is present, surgery well explained to the patient can offer an incremental benefit. The next is post-TB bronchiectasis, especially if it is localized and the patient is having recurrent symptoms. It is important to understand that the disease has to be resectable and the patient's symptoms have to be significant enough to merit a procedure. And then we should definitely offer surgery to these patients. And we can sometimes get away with the segmental resection, especially if it is a bilateral disease. If it is a unilateral bronchiectasis, often lobectomy is a preferred option, because TB, as we know, grows like a tree in bud appearance. And then sometimes the post-TB bronchiectasis is much more greater in extent than you can see radiologically. But yes, an extensive radiological planning is essential to modify treatment. And as I was mentioning earlier, the outcomes with the recent refinements are improving further and further. So the third is a destroyed lung. So a destroyed lung is wherein the mediastinum rotates. I'm sorry, I don't have an image today. It's a completely unilateral lung which is destroyed after pulmonary tuberculosis. So these patients would generally be young patients. They will be in their 30s. It will be a lean and thin patient who will keep getting admitted every 3 months with symptoms of recurrent chest infection or sometimes hemoptysis. The chest X-ray will show reduced lung volume, cavities, bronchiectasis, fibrosis, and these are another very significant group of patients who can be cured by a surgical procedure. So as we've started with the destroyed lung, so this is the principles of offering a pneumonectomy. You have to assess the patient, his functional suitability, do a proper preoperative optimization, explain the risk to the patient. These are not surgeries that can be done just, for cancer, people are moving away from pneumonectomy far and far. But in post-TB destroyed lung, there is not much pulmonary function loss if we remove the deceased non-perfused segment of the lung. So yes, they should be offered. So talking about other procedures, the standard procedures for TB would be a wedge resection, a segmentectomy, a lobectomy, or a pneumonectomy. And I would also talk about thoracoplasty here, which is again an important open procedure that is getting forgotten but should not be. So before we move further, I want to really stress here that not every case of TB is amenable for lung resection. The disease has to be localized enough for us to offer surgery. Whenever possible, if it is unless it is very small segmental disease, lobectomy is the preferred option, and pneumonectomy should be discouraged unless it is a completely destroyed lung. Localized bilateral disease, you can offer bilateral segmental resections versus a thoracoplasty based on the patient's general condition and tolerability for the procedure as per the PFT. Here again, I want to mention a very important point that most of our PFT studies of suitability of surgery are based on lung cancer patients. And when we look at PFTs of patients who have destroyed lungs, who have post TB lungs, the contribution of these non perfused segments is much lesser. So, our classical 30% predicted post-operative criteria may not fit a lot of these patients, and we should not just rely on the standardized PFT criteria for declaring a patient unfit for surgery. But yes, if there are patients who have a very poor general condition, then thoracoplasty can be the curative option. Tuberculomas, whether to resect or leave alone, is an area of equipoise, and I will not be discussing that today because of the paucity of time. So, bilateral extensive disease, disseminated tuberculosis, or an active bronchial disease. In a patient with a sequelae, also, we have to do an FOB, rule out active bronchial TB, because if there is active bronchial stenosis, then sometimes those terms will never heal. Patient unable to tolerate based on PFT criteria, but again, take that with a pinch of salt because the criteria standardized for lung cancer are not as applicable for inflammatory lung disease, and we are still to define criteria for inflammatory lung disease, and we hope to do that in the times to come. And if the patient is unfit to tolerate, then these patients are better left alone. So do your imaging, do your functional testing, optimize the patient preoperatively, optimize the nutrition, stop the smoking, control the active hemoptysis, and then we take up the patient for a lobectomy. I'm sorry I've used some of the images which are for VATS, but just to show the technical differences between a VATS lobectomy and an open lobectomy. You'll find too many of these adhesions. You will find a lot of inflammation at the hilum. You will find that these are much more bloody surgeries, and you will find that the vessels are more often than not a little more stiffer than what you find in lung cancer. So these are some of the intraoperative considerations that I wanted to highlight. So if you look at this image, you can see that the lung is well visible, but adhesions are there from top to bottom, whether it is from the chest wall, whether it is the hilum. At all places in TB surgery, you will find adhesions, adhesions, and adhesions. Sometimes adhesiolysis would be the time when you'll be tired. 3 hours sometimes go on in an adhesiolysis. Second important difference is calcified or densely fibrotic lymph nodes sitting on the vessels. So yes, with immunotherapy, a lot of surgeons are getting used to or understanding the hang of this, but we must remember that calcified nodes in TB are not necessarily to be removed. If there is a dense inflammation at the hilum, sometimes it is wiser to avoid trying to dissect the node than going ahead and dissecting the node. The other important intraoperative considerations are that you must always maintain the cavity integrity. We cannot afford a contamination. If the fungus opens up and there's a contamination, then the patient not only needs 6 months of antifungal therapy, but it also makes life difficult for the patient. There are much higher risk of complications. We have to strike a very fine balance between complete resection and parenchyma preservation because these are borderline patients. They will never be 100% fit patients. Stump reinforcement, especially in patients with a pneumonectomy. Expect apical space problems, especially in patients with an aspergilloma. And sometimes in aspergilloma, you must prefer an extra pleural dissection to prevent major injury to the subclavian vessels because these cases are sometimes poorly stuck at the apex. So if you've done a good job, you don't see the space problems. But as you can see here, there is a small space here. Sometimes it goes away with suction. Sometimes we accept the space. And if we are expecting a huge space problem, then you can do things like pleural tenting, diaphragmatic phrenic nerve temporary paralysis, or just put a tent of pleura over here. Now I want to mention a procedure which is sometimes forgotten, which is known as a thoracoplasty.
It's showing the video.
So, especially in patients who are unfit for tolerating a major lung resection, a cavernostomy with a thoracoplasty, it looks disfiguring on the images. But it is something like this that we are doing to the chest of the patient. But these are the patients who will, one, stop their hemoptysis, two, be back to normal life. When they remove their shirts, yes, it looks like half the chest is gone. But one of our patients has climbed the Siachen mountains after undergoing this procedure. Somebody who was living with the disease for 6 years is today disease free. So, yes, this procedure, which was the workhorse of TB surgery once upon a time, still has relevance in selected cases, especially for open surgery. So these are the patients who have been offered a pneumonectomy for destroyed lung. As you can see here, the mediastinum is already shifted. You can see the trachea is going straight till here on day one of surgery. This is not because we have not kept the drain, but because in destroyed lungs, mediastinum staying central is very uncommon. So post-operative care would include a respiratory care, a drainage management, proper antimicrobial planning, whether to give or not to give antifungals, and active mobilization and nutrition. As we talked about space problems, sometimes it is essential to make sure that we are forcing our patients to do aggressive physiotherapy so that that portion of lung which is not diseased can occupy the space left by the diseased inflammatory debris inside the chest. So operative mortality has come down to less than 5%. Overall complication rate has also reduced to less than 10%. Some certain non-specific complications like persistent air leak persist, but with digital suction devices, these are not as big problems as they used to be. Bronchopleural fistula rate is higher in post-TB sequelae surgery, and we should take steps to optimize them, and we have steps to correct this pathology if it occurs. So this should not be a reason to not offer surgery. 98% of our patients would be thankful that we offered them surgery. And yes, bronchoplastic and parenchyma space saving surgeries are the way to go. Just like in the lung cancer space, we are evolving in the inflammatory space as well. Another important area which I'll just touch upon very briefly is empyema thoracis, which is again a post-TB sequelae, which can be either a stage 2 empyema or as bad as a stage 3 empyema with significant calcification. And most of these patients, we are able to offer them good cure with a proper decortication. I will not go too much into the videos of the decortication because of the paucity of time. But these are the patients with trapped lungs after tuberculosis, extensive rib crowding, who can all be offered, especially in today's times, even minimally invasive ways in which we can remove all this fibrous tissue and give their lungs the space to breathe. So this is the amount of tissue that is removed, and these are the X-rays that we see after major decortications. And with expertise, now we are moving towards VATS decortications. Once upon a time, we were doing these cases by open technique, but now we are moving forward with this thing. Another important open procedure that I wanted to mention and highlight was a thoracostoma. So any patient who has had an ICD for a long time, is debilitated, does not fit any criteria for any surgical procedure, has multiple BPFs and decortication is unlikely to work, you put in a scope, you check whether decortication will work. And if you think that the decortication is not going to work, then doing a simple procedure called a thoracostoma, that is removing 3 centimeter segments of two ribs and exteriorizing this first cavity, can be the game changer. Yes, it looks like a surgery which can uh, really look bad, or in your mindset may seem like a bad procedure, but we've seen that these patients, despite the window that you will see here, have had complete lung expansions, and after some time they've even forgotten that they had the disease. They've had not just good response to treatment. This is just exteriorization. There's a lung which is compressed. There are multiple BPFs. There is two bones which have been cut, and now we are going to suture them to the chest wall. It's just a plurocutaneous window. But these are some of the patients who can, after this procedure, have complete, I mean, from this position, they can achieve this position either by themselves or by an additive procedure called vac dressing, which can actually improve their quality of life and help the lung to heal. Because a prolonged tube sometimes is the cause for a fistula to not heal. And this is one procedure which can make that difference for the patient. So before I end, I just want to highlight certain misconceptions. Surgery does not cure all TB, but it has a very important adjunctive role. Surgery in TB is not outdated. In fact, there is a resurgence with the epidemic of MDR and XDR TB. Thoracoplasty is not an obsolete procedure. It is relevant both in patients of fungomas, wherein you do a cavernostomy with the thoracoplasty, and in recalcitrant empymas. No, it does not have a high mortality anymore. Resection will not avoid antibiotics, but improve the penetration of the antibiotics. And embolization is not definitive. So if your patient is having hemoptysis, additive surgery matters. So with this, I would like to thank you for the time. Thank you.
Yeah, I think a great presentation. Yeah, Vijay, I think you are next. Or we can have the moderation later on. Yeah.
My screen is visible, sir?
Very much visible.
Yeah. Thank you, sir. Thank you for the kind introduction, and thanks to STS for collaborating with ISTS and to give importance to such an under-recognized and under treated diseases, particularly TB surgery, and to give importance to minimal invasive surgery in this field. When we think about VATS or robotic lung dissections, typically majority of the literature, when you search, you typically get it on lung cancers. So that itself shows how much it is the importance is given to this inflammatory lung diseases. Ironically, when you think about history of VATS, it evolved from inflammatory lung diseases. As we all know, Jacobius started this innovation of thoracoscopy using a cystoscope to facilitate pneumothoraxis in TB patients in earlier eras. As mentioned my other co-speaker, Dr. Pallavi, empyemothorax is one of the commonest diseases when we deal with infective lung diseases, either TB or other infective. And now the literature is very well established, at least in stage 2 empyema. And definitely, even in stage 3 empyemas, a lot of upcoming studies have shown good outcomes, particularly with good case selection. And we ourselves from our previous institute have published our experience with 100 cases of stage 3 TB empyema by VATS decortication in Annals of Thoracic Surgery back in 2017 itself. Coming to lung resections in infective lung diseases, as mentioned by our previous speaker, commonest is post-TB or post-infective sequelae, including aspergillomas, cavitary lesions, and bronchiectasis, which is already mentioned. And from surgical point of view, we deal with chronic pulmonary or cavitating pulmonary aspergillosis. And as mentioned earlier, classification include simple lesions, peripheral localized lesions, or sometimes complex when the entire lung parenchyma or a lobe is involved with lot of pleural thickening and surrounding lung involvement and consolidation as well. Surgeries can range from between wedge resections to segmentectomies, lobectomies, pneumonectomies occasionally, and as mentioned earlier, thoracoplasties and occasionally, very rarely, cavernostomies as well. And as seen with the open topic from my earlier speaker, there is so much of surgical difficulties we face in this group of patients. The commonest are pleural adhesions, risk of bleeding from collateral vessels, and spillage from cavity or aspergillomas, which can lead to complications in the post-operative settings. Commonest include prolonged air leaks, bronchopleural fistulas, empyemas, and sometimes fatal hemorrhages. So obviously, considering all these issues, our natural selection would be to go by open approach because we are comfortable with dealing with these things. However, VATS has made inroad into these cases as well with growing expertise and innovations, particularly in technology, camera systems, energy devices, and instrumentations. we're able to deal with these complex cases. This is how you see a pleural cavity when you enter into any of the inflammatory or infective lung diseases. So we used to convert to open procedures earlier in majority of the cases, but now we have started learning to deal with these things in minimal invasive way, utilizing all the advances in instrumentations and energy devices. Particularly energy devices have helped to kind of control the bleeding and hemorrhage, and we are able to do kind of bloodless surgeries even in these complex cases as well. So it might take an hour or two sometimes in very difficult case. In this case, you can see the whole lung is plastered completely, and you take a lot of time to mobilize this. But I would say even in difficult cases like this, it's worth to spend some time in achieving a good mobilization and particularly attaining attention to hemostasis. So we're able to deal with these kind of cases in minimal invasive way nowadays. And even in literature, you can see a lot of case reports, including effectiveness and safety of VATS procedures, both in pulmonary aspergillomas. This was one of the articles published in Annals of Thoracic way back in 2014, where around 76 patients were treated by a VATS approach with conversion rate of around 10 to 12%. And even long-term outcomes have been proven in this group of patients, and as comparable outcomes have been demonstrated in comparison to open approach as well. And now we know lot of innovations and developments have been happening in single port surgery, or what we call uniportal VAT surgery, and particularly thanks to Dr. Diego, who has kind of popularized this technique. And even this has also been demonstrated in one of these recent articles in pulmonary aspergilloma as well, with comparable outcomes and safety and feasibility even in aspergillomas as well. And coming to bleeding, as mentioned earlier, even bronchial artery embolization can be used either preoperative setting to control the hemoptysis, or as a preoperative optimization to control intraoperative blood loss, which was depicted in one of these articles from All University of Medical Sciences from my previous lecture, and which has helped to reduce the intraoperative bleeding and control the blood loss. There was an article which raised a question about, is VAT safe in patients with hemoptysis? So in this article published in 2023, 63 cases of VATS procedures were done for bronchiectasis and aspergillomas who had active hemoptysis, and they have showed that it is effective and safe even in this group of patients. But selecting proper cases, particularly with uncomplicated hemoptysis, and when the hemodynamics and the vitals were stable, and they have shown efficacy even in this situation as well. And from my previous institute, from Sir Gangaram Hospital, New Delhi, we have published an article in 2017 about 23 cases of VATS procedures attempted by for aspergillomas with a good outcomes and around 12% of conversion rate as well. So in one of these guideline statements from ERS Society itself, you can see in chronic pulmonary aspergillomas, VATS has been advocated as a preferred approach to manage these cases whenever it's feasible in this situation. Coming to the second disease we commonly face in inflammatory conditions, that's bronchiectasis, as mentioned earlier. And we evolved a lot from diagnosing this disease. I think you can recognize this picture. It was a case image of bronchogram, which was done in, I think, very old times. If you ask me, we have not seen this procedure done nowadays, but we have evolved a lot to high resolution CT scans and now 3D reconstructions to diagnose this disease. And etiologies can be congenital or acquired. And in our country settings, we see a lot of post-infective, particularly post-TB conditions. As mentioned earlier, the concerns include bleeding, but the added concern compared to the aspergillomas are lot of peribronchial inflammation in bronchiectasis, which can lead to enlargement of lymph nodes and fibrosis, which can tether the blood vessels to the bronchus, which makes our life difficult when we do the dissection, particularly in minimal invasive approach. And another added concern in this group of diseases is bilateral distribution, sometimes extensive involvement, or the whole lung and lobes are involved, and bilateral diseases. When I try to understand the differences between bronchiectasis and other inflammatory diseases, what I realized was the centripetal flow of inflammation because of the secretions pooling around the bronchial tree pathways, which leads to congregation of inflammation towards the hilum, which makes the involvement of lymph nodes, which are typically situated between bronchus and the vessels, leading to strong adhesions, making our dissection and surgery difficult. But even in this case, lot of VATS literature has coming up now, and including single port VATS, multi-port VATS, and this one of this study from Shanghai Pulmonary Hospital published in 2024 showed around 64 cases of VATS done for bronchiectasis with conversion rate of around 14%. So proving its efficacy and feasibility, and even including long-term outcomes in this study by Professor Hossein, and showing comparable long-term outcomes compared to open surgeries as well. And as with any other bronchiectasis surgeries, the completeness of resection gives a good long-term outcomes. And even in bilateral diseases, there are published literature on single-stage thoracoscopic resection in bilateral conditions. In this study, there are 23 patients where they are managed in single sitting, and they're able to tolerate well. And so it's also pertaining to good case selection in these cases. When you thought about segmental resection from bronchiectasis, even though it has been kind of an evolutionary part of thoracic surgery with bronchiectasis surgery, but when you look at as a separate literature, there is not much of dedicated literature on that. But there are few cases in the existing case series of VATS earlier studies. If you ask me, is it complex? Yes, definitely it's more complex. However, now recently we are not seeing that kind of a volumes of segmental diseases with bronchiectasis. We don't know whether it's because of late presentation or evolving disease biology or prolonged medical management. I just wanted to share this video of an open segmentectomy, which I actually borrowed from my mentor, Dr. S.V. Sri Krishna. This was a case of localized bronchiectasis in the right lower lobe, where you can see the segmental bronchus control has been taken. This was done by manual separation method, which we know as finger fracture method. Initially, when I saw this procedure, I was
Dr.
totally
Vijay,
shocked.
I just wanted to ask you, can you mute the video on the screen? Because all we hear is music. We want to hear what you're saying. Thank you. Perfect.
But if you know your anatomy well, you can do this surgery, and it is being done in the past and demonstrated, and patients are still had very good outcomes with these procedures. But I think one day we can replicate this procedure in minimal invasive OI. I hope for it. However, in recent times, I encountered on this interesting article about a Gilliton approach for lobectomy, in particularly inflammatory lung diseases, where they demonstrated simultaneous stapling of lobar artery and bronchus. That's where I think we find the majority of difficulties in these inflammatory diseases. And they have showed in 31 cases out of 50 cases with no significant difference in either short-term or long-term outcomes. And they mentioned that it helped to reduce the duration of surgery. This shows the intraoperative image where both the bronchus and the fissure and the artery are simultaneously divided with a very thick stapler after taking down the vein. I think it's a very good added adjunct in our armamentarium to deal with these difficult cases, occasionally at least. When we think about robotic approach, as we know, it has made a lot of name and fame in the oncology field. But when you ask about inflammatory lung diseases, there is a lot of limitation in the literature. This is one of our earlier case reports from my previous institute, which we published in 2015, which I was happy to be part of, where around I think 15 cases of robotic procedures were done, including few inflammatory lung diseases as well. And another case report from Dr. Ali Zamir Khan from India, which was published in Annals of Cardiothoracic in 2019, where he demonstrated feasibility of robotic approach in inflammatory lung diseases, including aspergilloma, bronchiectasis, and even in destroyed lung as well. As with all the other minimal invasive procedures in thoracic now, uniportal robotic, popularized by Diego, has taken over, at least in oncology, but he has also done few cases even in inflammatory lung diseases. I think this is one of the case report from India, along with Dr. Diego, about uniportal robotics in aspergilloma. Just wanted to share a recent experience of our case where we did a uniportal robotic approach for a completely destroyed left upper lobe. As seen in previous speaker's talk also, you can see strong adhesions everywhere. Chest wall, pleura, diaphragm, hilum, and more so to make our job more difficult, these enlarged, sometimes calcified, strongly stuck nodes, which make dissection even more difficult. And many times, you see, your adhesiolysis itself takes hour and a two just to get the lung down completely. And as you can see now, you can appreciate the difference between the bronchiectatic segment on the upper side and a relatively spared lobe on the lower lobe. I would say the robotic with its miniature arms
Dr.
and
Vijay,
articulation. Yes,
Dr.
sir.
Vijay, can I just ask you to try to conclude as fast as possible because we have Dr.
Yes, sir.
Mitchell.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. So I encountered on this uniportal robotic surgery article recently from India, which has shown effectiveness even in inflammatory lung diseases, even in destroyed lungs like pneumonectomies. Minimal invasive surgery can be attempted, and there was this article which showed around 15 cases were done by VATS approach. A small video where we did a recent case of uniportal robotic pneumonectomy in a post-TB destroyed lung as well. You can appreciate the differences, but this robotic instruments give a lot of advantages in manipulating this narrow space and to get these difficult vessels looped and divided with safety. Yeah. Just sharing our modest experience with minimal invasive thoracic surgery for these cases, around 50 cases, out of which 40 were VATS, including both lobectomy, pneumonectomy, and segmentectomy as well, with around conversion rate of around 15%. This was our robotic experience, including uniportal robotic, with at least zero conversion. I think it's our initial beginner's luck. To conclude, minimal invasive surgery, either VATS or robotic, is definitely feasible, but you have to be very super selective in your cases. Definitely, it takes a longer learning curve, but always keep safety in mind, and we should take conversion not as a failure, but as a step to success. Thank you.
Thank you. I think we can take it further. Dr. Madhuri, we can ask, I think, Dr. Mitchell also to give his presentation and then have the discussion at the end.
Agreed. Thank you.
Why don't we stop sharing and I'll share.
Yeah.
All right. I hope everybody can see that.
Yes, you're good to
All
go,
right.
Dr. Mitchell.
Terrific. Well, I want to thank everybody for the opportunity to be here today. Couple of things, in the U.S., by far and away, the most common topic in thoracic surgery is malignancy. And so it's a real pleasure for me to be able to interact in this environment where we talk about infectious lung disease, something that I care a lot about. The other thing is the topic that I was given, we could spend the whole weekend on, and I have 12 minutes. So I'm going to be a little selective about what I talk about. Here are my disclosures. So you might wonder why somebody from Denver, Colorado, which is in the middle of the US, might be so interested in infectious lung disease. It's because in Denver, there is an institution called National Jewish that was originally a TB SAN. This picture is from over a century ago, but now has morphed into this large clinical and research institute. And most people feel National Jewish is the preeminent respiratory hospital in the United States. So they still have a big service line in mycobacterial and infectious lung disease. And I do the surgery for them and have for the last 20, 25 years. And before me, my old partner, Marv Pomerantz, did the surgery. So I go over there every week. We talk about cases for which surgery might be appropriate. Now, we certainly see drug-resistant tuberculosis in the US, but it's, as you guys know, it's pretty rare due to public health efforts. So this is not the major focus of what we do. It used to be 20 or 30 years ago, but not as much anymore. So during this talk, I've decided to talk about non-tuberculous mycobacterial infection and then some endemic fungal infections that if you were a thoracic surgeon in North America, you might see. Starting with NTM. So everybody's familiar with atypical mycobacteria. It's called a lot of different things, but really the best term, I think, is non-tuberculous mycobacteria. It's ubiquitous. It's found everywhere in the US and elsewhere. It's very hard to disinfect or kill with standard sterilization techniques. It's not an obligate pathogen, but there's no person-to-person transmission. So some people get it, some people don't, and the reasons why are not totally clear. Comparing it to TB, I mean, both types of bacteria are AFB positive. It's a little controversial, but really no person-to-person transmission with NTM. Because of that, it's not a reportable disease, at least within the United States. But the incidence is clearly increasing, or probably it's being recognized more and more. Our patients with this problem come from all over the country. And just like with TB, significant drug resistance is really causing some issues with treatment. So there's over 150 types of NTM that can be speciated. Microbiologists kind of break it into slow-growing mycobacteria and rapid growers, as you can see. The most common slow-growing mycobacteria are those within the MAC or MAC group. So that includes M. avium, M. intracellulare, et cetera. By far the most common that we deal with. Within the rapid growers, the most common one is M. abscessus. It's very difficult to treat, and surgery can play a prominent role. Patients present with three different types of clinical scenarios. The first, middle-aged women, typically thin, typically Caucasian, non-smokers, who present with right middle lobe and lingular disease, the so-called Lady Windermere syndrome. People can present with isolated thick-walled cavitary disease. And then occasionally we'll see folks with a totally destroyed lung, as you can see here, usually those with pre-existing COPD. So what are the indications for surgery in people with pulmonary NTM infection? Well, they typically have persistent parenchymal lung disease that is still there after antimicrobial treatment. Usually they have recurrent symptoms. Usually they've been treated multiple times and have failed and or have developed significant antimicrobial resistance. Surgical resection, just like in other forms of infectious lung disease, usually is an adjunct to antimicrobial therapy. So you don't treat NTM infection with surgery by itself. Usually it's combined with medical treatment. So at our institution, a couple of things. How do we treat these people? Usually they've been previously treated for years, and despite good guidelines, they come in with guideline deficient therapy. So the first thing we do is relook at everything, put them on an improved drug regimen. Often that includes parenteral medications such as amikacin. It's incredibly important that if you have a program like this, I think, to have a multidisciplinary approach. So I meet every week with ID specialists, pulmonologists, et cetera, and we talk about how to incorporate surgery within the treatment paradigm for these patients. Oh, sorry about that. So they get put on a new regimen, then come back 8 or 12 weeks later for their surgery to Denver. We need to optimize many other factors involving the patient, airway clearance issues, nutritional status for people with more significant disease burden. And if they're going to have bilateral surgery, we plan the second surgery about 6 weeks later, typically, although it can be much sooner. So when we operate on these people, we say, well, what is our goal? What are we trying to achieve? Well, just like with tuberculosis surgery, one of the main goals is to try to eradicate the infection, make them culture negative, off antibiotics, symptom free. Occasionally, we will operate on folks for intractable symptoms like a cough or recurrent hemoptysis. And rarely, people will present with a totally destroyed lung on one side and then some disease on the contralateral side. And we will consider pneumonectomy on the bad side simply to limit or slow the progression of the disease. So there have been many published studies about NTM surgery. We need to update our series. I've now done over 1,000 of these cases, and you can see in all of these studies, particularly the more recent ones, the mortality rates are low, morbidity is low, BPF, while not zero, is reasonably low, and very high sputum conversion rates. So most of these cases I now do robotically, including the two that you see here. Very focal disease, very amenable to robotic resection. We almost always do either lobectomy or segmentectomy, or a combination. It's important to realize that just as with tuberculosis, though, there are some things that you can't or shouldn't approach minimally invasively. This is an example of a totally destroyed right upper lobe. I think this patient, I operate on this patient, and we dissect this free extrapleurally to minimize the risk of spillage within the pleural space. And how do these people do? This is a gal that I operated on, and she had Lady Windermere syndrome, and you can see in the lower right of the picture, this is 17 days after her first side, say her right middle lobectomy, and 4 days after her lingulectomy. And she's rewarding herself. She's in a shopping center buying something expensive. So she came from San Francisco, and the bottom line is people do well after this sort of surgery. But I would hasten to add that there are aspects of NTM surgery that are just like drug-resistant tuberculosis. This is a study from Japan that compares outcomes after pneumonectomy for people with drug-resistant TB versus NTM disease. And no one died within the study. The MDR patients had a much higher rate of sputum negativity prior to surgery and a very much lower BPF rate, probably in part because of the predominance of left-sided disease. On the NTM side, though, you can see very difficult to control infections, very low conversion prior to surgery with a very high BPF rate. So NTM surgery can be very daunting, and it can vary from very straightforward, like the woman I just showed you, to very high risk. I'm going to shift gears and talk about some typical fungal diseases. We've heard a lot about aspergilloma, and I know everybody sees this. Most people at some point will develop hemoptysis, and we tend to be very aggressive about treating these people. This is someone with more complex disease that you can see here. I operate on this patient as well, but certainly not minimally invasively. There's the inside. Everybody knows what that looks like. So when someone in America comes in with hemoptysis related to an aspergilloma, I mean, bronchial artery embolization, if the hemoptysis is significant, is really the first line treatment. And it's a temporizing measure. I tell people your hemoptysis is very likely to come back. So if the surgical profile and risk profile is reasonable, we will go ahead and resect this, either typically with a segmentectomy or maybe a lobectomy. And as previously stated, the morbidity and mortality of these procedures is pretty low nowadays. If folks have complex cavitary aspergillosis and they are deemed not surgical candidates, they're treated with lifelong antifungal treatment. And as everybody knows, there are a variety of surgical adjuncts for some of these high-risk people to deal with the aspergilloma if needed. So a question, our residents would say, well, if someone's totally asymptomatic, should the aspergilloma be removed? And I think in folks with a favorable risk profile, it probably should be, because the majority will develop hemoptysis at some point. And it's a scary thing, as everybody knows, if the hemoptysis progresses to be massive. This is another controversial subject. Should everybody get antifungal therapy around the time of their surgery? Well, I would tell you, when I see aspergilloma patients, they're almost always already on it by their pulmonologist. I don't know of data that suggests it's really helpful, particularly for simple aspergillomas. Certainly more complex disease, it certainly might be. And can you do this minimally invasively? And the answer is, well, yes, that definitely can be removed robotically. And I don't think that should be done that way. No, no, no. ABPA was mentioned briefly, and there's no real role for surgeons here other than to recognize it. You see the fingers in the glove, sort of mid-lung zone pictures of the inspissated mucus plugging within the airways. You see this in asthma patients, CF patients. The treatment for this is steroids, with or without antifungal agents. So it's for the thoracic surgeon, it's something to recognize rather than likely treat. And then invasive aspergillosis, usually seen in immunocompromised patients. They present with fever, cough, sputum production, hemoptysis, can have pain, can have this typical halo sign that you see in the lower right. It is characteristic of this sort of problem. The role for surgery here is limited and selective in nature. These patients are usually treated with IV voriconazole or some other antifungal agent. You need to reverse the immunosuppression, and then you might get called occasionally to see these folks, typically in the bone marrow unit or something like that, where occasionally addressing surgically a focal lesion might be beneficial to the patient. Now, a couple of other endemic fungal diseases within the US. One is called coccidiomycosis or valley fever. You can see it is centered in the desert southwest area of the United States. So think Arizona. It's very common. It's in the soil or in the desert soil, and it's inhaled. The infection can occur a couple of weeks after exposure. Most people don't even know they had it, and it gets better. If they have a severe episode of disease, they can be treated, and once the diagnosis is made with antifungal agents. The way this affects surgeons is that afterwards, you can develop nodules within the lung as a sequela of the infection, or even cavities. So that's a typical coccigranuloma you can see within the left upper lobe, and you can see how it would be confused with a malignancy. So this is how this comes to the forefront for surgeons. Here's an example of a cocci cavity. So if someone shows up in your clinic with a nodule, gets biopsied, they're asymptomatic, you're worried it's cancer, and the finding comes back with consistent with cocci, do you need to treat them? And the answer is no, you do not usually need to treat them. Do you need to excise it? The answer is no, you do not. If the cavity that I showed previously was treated with antifungal agents but continued to get bigger or cause symptoms, that would be an indication to intervene with surgery. But often the cavities will shrink and go away. And then finally, if you go in and say you're doing a robotic wedge for diagnostic purposes, and the frozen section calls back and said, this looks like a a cocci-granuloma, you need to offer antifungal treatment? And again, the answer is no. Histoplasmosis occurs in the center of the United States that you can see there. It also is endemic. It's in the Mississippi and Ohio River valleys. So central part, we call it the Midwest. And I bet Dr. Rao, even up in Minnesota, sees many patients like this. So you, again, endemic in the soil, you inhale them, they can produce caseating granulomas in the lungs and in the lymph nodes. Particularly in the lymph nodes, the granulomas can calcify, and you can see this in older people as they travel around the US, so we see that all the time as well. Usually it presents with a flu-like illness. People don't even know they have histoplasmosis, and they only get treated if they have severe cases. And typically they're treated with either oral antifungal agents such as itraconazole, or for more severe cases, liposomal ampho B with or without steroids. There's a diffuse form. No one could miss that on this CT scan. And again, it's usually seen in immunocompromised patients and again treated with antifungal agents. If people have chronic cavitary pulmonary histoplasmosis, they're treated lifelong with itraconazole. People that develop the calcified granulomas within the chest, the antifungal agents will not affect or reduce the issues related to those, so they're not given. What those calcified nodules can do later on is cause compressive symptoms, fibrosing mediastinitis, and the calcified nodes can erode into the airway, as you see here. So then the surgeon needs to intervene, but very selectively and very selectively. So typically it's not a disease that's addressed unless it needs to be done. If you have someone with fibrosing mediastinitis or bronchiolithiasis as shown, should you give them antifungal agents? Usually it has no effect on the disease at that point. And then finally, the last thing I want to talk about is mucormycosis. It too is ubiquitous within the soils, and people inhale these things. It's very rare, and usually you see it in immunocompromised patients. So typically you'd get called to the bone marrow unit, someone who's severely immunocompromised, typically on a Friday afternoon, as everybody knows, poorly controlled diabetes. They'll be symptomatic with fever, cough, chest pain, etc. The problem with mucor is it can be a very rapidly progressive infection, invasive mucormycosis. The reverse halo sign is that ground glass in the middle surrounded by the atelectatic lung or consolidated lung. So the presentation is similar to invasive pulmonary aspergillosis, but much more severe. And once diagnosed, people are treated with antifungal agents. But in addition, this is really a surgical emergency, if you will. Surgery can play a huge role in the outcome of these patients. The mortality rate for invasive mucor is over 50%. But if aggressive surgical debridement and resection for pulmonary mucor is employed, the mortality can be significantly reduced. That's all I have. Thank you very much, and thank you for allowing me to participate.
Thank you so much. And I think all of us will agree that all the three speakers have done a wonderful job. And those of us who work in the infectious lung disease sphere as thoracic surgeons know the challenges that thoracic surgery in this area presents to us, and how much rewarding it is to the patients, especially those who have been suffering for a long time with their medical conditions. So before handing over, there are some specific questions to Dr. Mitchell first, if I may ask. So in the NTM category, which kind of mycobacteria do you see most commonly? In our part, we generally see Candidacea and very rarely MAC and very rarely abscesses. So which one do you see more?
Yeah,
very
that's
often.
very interesting. We see Kenzesai. I probably operate one or two a year, but Mac is the most common. It's probably 75%, some variant of Mycobacterium avium. We see a significant number of abscessus patients only because the people come from all over the country and it's so difficult to treat. Abscessus is one of those things where it's very difficult to eradicate medically. And so surgery has been shown to really impact the we don't really think of it as cure, but getting them culture negative off antibiotics. So I'd say MAC, M. abscessus, and then the other ones, Zanopi and Kenzesai to a lesser degree.
Okay. Okay. You see, in India, in our own institute, sometimes we have been able to isolate NTM in more than 200 cases. The surgically treatable cases are very few in number. And of course, as you rightly said, complications in NTM surgery are slightly higher than those seen in TB surgery. That rate remains the same. And mucormycosis, we saw a lot during the COVID pandemic. And we successfully operated many cases, and simultaneously we saw very bad results too in several cases. But surgery had to be resorted to in several cases in the post-COVID period. I mean, patients coming out of COVID, admitted cases. So we had a huge number. And one surgeon in India had actually published a series also, long series of cases of mucormycosis following COVID pandemic.
Ooh.
And I think, thank you so much for that presentation. Over to Dr. Rajan for further interventions. There are a few questions on the chat also.
Yeah,
and
sure.
Over to Dr. Rajan. Yes.
Thanks, Divan. See, I have been exposed to TB from my childhood because my father ran a TB sanatorium. And I have learned to do thoracoplasty. Those days, in the pre-antibiotic era, we used to do thoracoplasty under local anesthesia. No double lumen tubes, no diathermy, and patient had cough reflex had to be preserved, and you had to take care not to injure the pleura. So those were the old days, very difficult surgery, which I learned. And that is why I had a passion for thoracic surgery and took up thoracic surgery as a career. In India, during my early days of training, only everybody went to cardiac surgery. There was name, money, and fame, but things have changed. Over the years, I have seen fantastic results with VAT surgery, which my son does now, which I sit and watch with so much of less morbidity. Every angle in the chest can be seen, and every bleeding vessel can be taken care of by energy devices. So this is what has been my experience from the pre-antibiotic era to the modern era. And I have also visited Divan. Divan has visited me, and we had coordinated a lot of cases together. So I think that was and of course we do see Lady Windermere syndrome in our practice also, but rarely, but where middle lobe and lingular are affected. So I think it was a very nice discussion on infective lung diseases. Divan, you can coordinate the questions.
Yeah. Before concluding, I think there are some questions in the chat. Pallavi, you can address your timeline of giving ATT and antifungal therapy. What kind of a pathway do you follow? Because that's one question from Dr. Afai.
So, as far as ATT goes, the traditional teaching was that we used to wait for culture conversion in MDR and XDR TB. But nowadays, a lot of studies and reports are coming in wherein you hope for culture conversion. So, 2 months of ATT, a lot of people give, especially if it is bedaquiline based chemotherapy. And then, even if you have not achieved the culture conversion, surgery is not contraindicated. As far as for aspergillomas, there is no indication for any preoperative antifungal therapy, but mostly you will get patients who have been referred to you after they've taken months of antifungal therapy. The indication for post of antifungal therapy is also very small. Those are patients in which you have seen an intraoperative spillage or you find invasive aspergillosis once you get the histopathology from the report. But other than that, preoperative antifungal therapy is not recommended if you're doing a good surgery in an aspergilloma patient.
I think, as Dr. Mitchell has also said, the physicians have already started antifungal therapy, but as surgeons, we feel that this fungus is just a colonization in aspergillomas, and the therapy is probably not required, especially except in very selected cases. That's the situation. To Dr. Vijay, your presentation was very nice, and I can see that you are probably one of the leaders who has introduced the minimal access surgery for inflammatory lung disease, and now many young surgeons are taking up, as Pallavi has also shown. But from one thing which I found from your presentation, robotics, though Dr. Mitchell has shown that he does cases of robotic surgery. In your
Yes,
cases,
sir.
how much minimal access are you able to do by robotic and how much by traditional VATS approach?
Sir, in inflammatory lung diseases, I would say still around 70 to 80% is VATS approach, and another 10-20% is robotic approach. Mainly, I would say in our country setting, it's because of cost constraints, particularly with robotic approach. But yes, definitely we are increasing the utilization of robotic. As we are doing more robotic in oncology, we are understanding that it gives advantage even in these inflammatory diseases for safer dissections. But definitely it's on the uprising trends.
Right, right. And Dr. Pallavi, what is your comment about the digital portable chest drainage suction system? As a TB surgeon myself, I realized that when it was introduced, our post-operative complications rate reduced drastically. This technology has made a very singular difference in our post-operative results in TB surgery. So, do you want to comment on that?
Yes, sir, especially in aspergilloma patients, wherein having a residual apical space was a routine with these devices, that is coming lesser. So that also indirectly reduces the rate of empyema. So if you have a residual space, then it is likely to get more likely to get a. Although BPF or an alveolar pleural fistula is the most common cause for a post resection empyema, but these devices, as I showed in the images of post-operative X-rays, because of these devices, we have been able to reduce the rates of those cavities which are remnant. Even in patients of decortication, sometimes when you're doing a stage 3 calcified pleura, a digital drainage suction device is better for patient for ambulation also in the post-operative period. That suction is there running when the patient is ambulating. So it definitely helps his consolidated lungs to expand better.
And one question which I see in the chat is about the role of bronchoscopy in TB and inflammatory lung disease surgery. Any of the three speakers? I think Dr. Mitchell, your thoughts on that?
On performing bronchoscopy? Well, obviously in the setting of hemoptysis, I think localizing the source is key, and that's done bronchoscopically. Beyond that, we don't employ that to any great degree. I think so. I think I'd leave it at that.
Pallavi? Yeah.
But I would like to add, especially in patients of bronchiectasis, if they're coming with recurrent infections, it's a good idea to do a bronchoalveolar lavage and test it for TB once more before we subject these patients to surgery.
Okay. I think one of the important points was to see if a surgeon does a bronchoscopy to see that the proposed site of
Divan, I want to make
stump.
a comment about digital drain. I have
Yes.
never used digital drain.
Okay.
I have had no, I mean, as far as I'm concerned, in case I need suction, I use a 3-bottle suction, and I have had excellent results. Even though you have been talking about the digital drain, that I have not used, and I don't think it is really necessary. It's
Yeah.
each person is entitled to their opinion.
Correct.
Okay,
And I
thank
said, sir, because you mentioned, another point which Vijay had mentioned about simultaneous stapling of the artery and the bronchus. I saw Dr. Rajan doing even during open surgery. He will take a vein and then put a tie around the bronchus and the artery together, and it will do very well in inflammatory
Thank
case.
you.
You have a long experience.
See, the thing is, we used to do it earlier, but in the recent era, unless sometimes, as Vijay says, it is necessary. But most of the times, you're able to separate very carefully the artery and the bronchus. And rare conditions when especially if it tears, the artery tears, and you have the bronchus and the pulmonary artery there, you have to staple. You have no other choice. But as a routine, you'd prefer to dissect it and staple it separately. I have seen an ocean of difference in post-operative bleeding, morbidity after the minimally invasive approach. And unlike in the West, we see more cases of TB. And as we go on, now I don't do it, I sit and watch. but it has been a great lesson for me. How, especially in the areas where you can't see, for bleeding in inflammatory lung diseases, where surgery is become very, very useful in our center.
Yeah. Both of us have seen that VATS is very feasible and quite feasible in inflammatory lung disease now, and younger surgeons are showing the path. But as Dr. Mitchell has shown, few X-rays which should not be touched by VATS approach. They are best approached by traditional open approach. I think over to Dr. Madhuri for further taking on the discussion. Dr. Madhuri.
Yeah, thank you all very much. This was very educational, and I hope all our attendees made the best use of it as well. I know there were some other pending questions, but we can share our some contacts to be able to discuss this further. But in the interest of time, we're going to have to conclude now. Just a quick couple of announcements. There is a one of our surgeons from UAE had asked for this to be shared at the meeting. There is international conference, thoracic surgery conference in the Emirates that's coming up in April. So that's something to keep an eye out for. The other thing is that the STS and EACTS are going to be having a combined session at the IXCon in Mumbai. So that's something else, another thing for our folks in South Asia to keep an eye out for. But other than that, we'll keep continuing this collaboration. It's been very fruitful so far. Thanks to all of your contributions. Thank you. Anything you want to say, Cecilia?
No, again, a big thank you, especially for this kind of discussion and interaction. So happy to move this forward. Thank you so much, everyone.
Thank you. Dr. Srikrishnan?
Yes, I am sure that all of you have enjoyed these three presentations, done excellently. The final take-home message probably for the junior surgeons would be that inflammatory or infectious diseases are much more difficult to do rather than the cancers that we treat. And one must know one's own limitations and choose the right approach to the right patient, as which has already been highlighted, and keeping in mind the safety of the patient at all times. That's what I would like to conclude with this.
Thank you all very much. Have a great weekend.
Thank you.
Thank you so much.
Thank you.
Thank you.
Thank you so much to our co-sponsors, our esteemed moderators and panelists for your participation and insight. And thank you all to all the attendees for joining. We hope you have found this webinar valuable. If you're not already a member of STS, excuse me, you'll enjoy a variety of discounts, benefits, and opportunities to help you grow professionally. Use the QR code on the screen and sign up. Registration is now open for STS 2026 in New Orleans. Find out more information using the QR code and save the date for the ESTS meeting in Greece, which is happening June 7th through 9th. And lastly, mark your calendars for an upcoming STS webinar co-sponsored with the Society of Cardiovascular Anesthesiologists. Across the Drapes, Multidisciplinary Management in Esophagectomy. Thank you so much, everybody. Happy New Year, and hope to see you soon.
Thank you very much.
Thank you very much. Thank you.
Thank you, everybody. Thank you.
Thank you.